And there we go. And I love that voice. It's great. And then what we're going to do is slip in, and Yul and I are going to take turns. So we're going to present. We won't take more than 25 minutes to present. So hopefully there'll be a few minutes at least for some questions at the end. We'll try and be a bit quicker if we can. So here we go. Hopefully that will all work. Hopefully you can all see those slides now. If you can't, then do unmute yourself and shout. We're going to monitor the chat as best we can, but it's always tricky when we're doing this. So, okay. So, Yul, do you want to take it away?
Yeah, so we just thought we would just start with introduction. So my name is Juul. I'm a clinical psychologist. I am newly qualified, so I graduated in September last year, and basically this is the thesis project. And Ian, you were my supervisor, so you want to introduce yourself?
Yes, so I work in training clinical psychologists and as a researcher into various things related to therapy process, and particularly solution focused training and therapy processes. I work at Lancaster University in the UK, although next month I'm moving to Liverpool University. And as Yul says, I supervise this project that he's done as part of a rolling program of research that we're doing. Okay, so we've introduced ourselves. Let's set the scene.
Yeah, so just to kind of start it all off is just to mention a little bit of kind of background for this research project, and really the big kind of problem that this is relating to and trying to answer questions around is how do we bridge the gap between the increasing need for mental health support and the mental health needs that is present globally, and also obviously the limited resources. So there's an increasing mental health need, but there is that limited resources. How do we bridge that gap? How do we best spend our resources? And within the UK, there's been quite a lot of research around what could this solution be, and it's very much trying to ensure that there is an early access as possible for psychological support, at every stage of healthcare. So it could be primary care services, it could be hospitals, A&E even. So any kind of as early as possible.
Okay.
Sorry, I didn't catch that.
I'm not sure if that was intended for us or if that's just background of somebody.
I was about to say, yeah. Okay. So that's part of the research then was looking into how maybe clinical psychologists was kind of proposed to be able to use their skills and be able to offer consultation, supervision, but mainly training to kind of disseminate and share these kind of psychological resources with people who might not have a formal background in psychological therapy, so that they can offer kind of low-level therapeutic interventions at every stage of care. And so that really kind of meant that we need more research into the training itself and good training programs. If you want to go to the next one.
Yeah, will do. Sorry, there we go.
There we go. So solution-focused therapy was one of those models that was kind of proposed as, first of all, is quite an efficient model. Second of all, it's quite user-friendly. It doesn't require as much of that psychological theory in depth as, for example, psychodynamic models, for instance. It also was research indicating that it was quite high in personal allegiance. So that basically just means that people's personal values kind of matched with the model itself. And people were quite kind of emotive and connected with the model, which was quite a facilitator for it to be used in all of these different types of contexts. However, there's also research that's showed that there's quite a lot of barriers or different factors that are barriers to using solution-focused therapy after training. And just a list there, I'm not going to go through all of them, but really our research project was really looking at, okay, so there's lots of facilitators, there's lots of barriers. What does that look like? How do they interact with each other? And especially over time. And then lastly, just to mention a kind of background factor, which is that, we have a bit of an uphill battle when it comes to training, because only 10 to 30% of training is actually applied. A couple of research findings has been. So we're kind of keeping that in mind and trying to kind of push for therapy programs to be the most effective as possible.
Yeah, that's specifically research that's looked at training in therapy skills, brief therapy skills more generally. I'm just stopping and resharing for a moment rather than solution-focused therapy in particular. But let me just redo this. So I don't think it'll make any difference, but I'll just give us this effort. Yeah. we're both Zoom rookies because we usually use Microsoft Teams, so it's proving interesting for us. Okay, so yeah, the research question that we really wanted to know was to really understand how the people that had the training understood not that training, but their experience of it, what had been useful for them, what had worked, what had got in the way of that, and how all those factors really interacted. So digging underneath that, what we really wanted to get to was try and get an understanding of how people perceive those underlying mechanisms of what was going on in training, before training and after training, that really made the difference between somebody who then took up and used solution-focused therapy skills and somebody who didn't really do that at the end. So obviously, if we're able to do that, the ultimate aim is to be able to develop better and better training that will hopefully work and be more effective and be useful for more people. So the method that we used was relatively straightforward in terms of the procedure. We conducted, well, Juul conducted one-to-one interviews with people who'd completed solution-focused training at least 3 months prior, sometimes several years prior, to explore their experiences and say how they used the model, how they found the training, and what they did with it. We used grounded theory analysis, so many of you may be familiar with that, but if you're not, grounded theory is one of the oldest qualitative methods. And it's really helpful, particularly these days, for being able to actually look at connections between things, and particularly the way people perceive connections between things. So it's great for looking at mechanisms of how people see, think Y that's happening to them, resulting in them responding in way X. So it's really good at looking at kind of causal chains or perceived causal chains and things that might be kind of correlated or sit together, which is why it's great for looking at for this kind of thing. And also for areas where there isn't a lot of research already, it's great for actually just building a theory or a model that you can then test in other ways. So as I said, we did semi-structured interviews. There were 10 in total, about an hour each. And then the analysis process for grounded theory is quite interesting in that we did a first clutch of interviews, about 3 or 4, then analysed those to a certain extent, looked for patterns, for gaps, for things we didn't know, for things that seemed to be coming out, to then try and interview people to see if they got different experiences, to answer questions that we had. And so to do that in the next tranche of interviews, we adjusted the interview schedule, and we tried to select people with particular kinds of different experiences so we could explore the areas that we wanted to know more about. So overall, there were 10 participants. There were from a range of professions, but there were quite a lot of specialist nurses. That was the predominant profession that were being interviewed. All of them had completed a 2-day training program in solution-focused therapy, no more. The biggest variation really was that the training was fairly standard. Most was provided by the same organization, but it was the amount of time since it happened. So the minimum for inclusion was somebody had been trained at least 3 months ago, but several people have been trained 2+ even more years previously. Okay, so let's tell you what we found.
All right, so the most interesting part. So so really the outcome of this was that we developed a visual model, and it was a visual model that was chronological. And I'll explain all of this in the next slide, where I'll actually show the model itself. But just to kind of mention early on that what it actually consisted of, and then I'll explain it in the next slide. So we got 14 themes, and they were compressed as much as possible from a lot more, but we were able to compress them over time. And they had kind of an overarching a core category, which was 2 mental states in relation to using solution-focused therapy. And one of them was comfort zone, the other one was brave zone. Again, I'll explain it in a bit. And then there's also a subcategory that we developed, and it was 4 kind of internal states of processing. And they're each color-coded, and they're related to interest, motivation, belief, and confidence in terms of using solution-focused therapy. So you can move on to the...
Okay, here goes. Everybody ready?
Hopefully it's not too overstimulating. But in case it is, we'll go through each bit in the meantime, and Ian will be so kind to try and kind of help kind of show each bit as I go through it. But if you kind of move your eyes, I guess, to the top at first, thinking about this model, so is the kind of chronological side to it. So we were looking at what was happening before the training, what was happening. So that's the kind of on the left-hand side, what was happening during training, so in the middle, and then what was happening after training. So the model was kind of describing what was the change around using solution-focused therapy throughout. The next element that we would look closer into now is in the middle. You can see that there's an arrow. And this arrow is basically the use of solution-focused therapy over time. So it's a linear arrow, which basically means that we're very optimistic about people using focused therapy as much as possible. Yeah, exactly. But on the right-hand side that you were showing there, Ian, is in the blue is the actual use of solution-focused therapy after training. And then the kind of the white section at the bottom left is the preparation for using it. So kind of the pre-training and during training element. Then we also have the third element, which is the two zones that I mentioned earlier. So you have the brave zone at the top, and then you have the comfort zone at the bottom. Now, the comfort zone is the kind of the mental state that you're in when you feel comfortable, when you feel that you're familiar with something, when you feel, for example, it could be a model that you're very used to, a medical model, for instance, that you've used for a long time. That would be your comfort zone. And basically throughout training, we're asking you to go into the brave zone, to actually go beyond this comfort and go into the uncertainty, unfamiliarity. And you can see at the bottom is the comfort zone. Now, there's 7 themes at the bottom. All of them kind of have clouds around them. And these are the themes that helps kind of pull you down towards the comfort zone. That is, pulling you away from using the solution-focused therapy in practice. Whereas the top one, you can see, again, 7 kind of separate factors that is all related to the brave zone. And these elements help you push you upwards towards using solution-focused therapy. And finally, the last element is to mention these kind of these blobs that Ian is pointing at, which is the internal processing. So you have the interest, motivation, belief, and confidence. You can see that the boxes, the themes, have color-coded. So we'll go through now an example to kind of explain all of this per stage. Go ahead, Ian.
So we'll talk you through the bit by bit now with a little bit more detail. So let's zoom in on this first bit now.
We don't have extra hands.
Can you just go through and mute anyone that's not muted?
Yeah, I'm just.
I've got multiple things going on. The exhaustion started.
I'm not able to at the moment. Sorry, Ian.
Okay, just a second. Let me go and do that.
Find out where the person is. Hold on.
That's all right. Got them. Okay, there we go. Right. So yes. So as you were saying, that there are factors pulling you down, and what you'll notice in this part of the model is there's a lot of red. So red is about belief in the model, of belief that solution-focused therapy works, that it'll be useful for you. And I'll just quickly flip back to the previous slide, and you'll see there is an awful lot of red here in the pre-training and the training, during training areas. So actual belief in the model was one of the things that we identified that even more than we thought is really important. So some of the things that really made people not believe in the model, or that didn't augur well for success in future later on, were first of all not having seen somebody do solution-focused work and it working well. So not seeing the practice work and be successful. So the importance of that, remember, this is pre-training. So this is before somebody gets trained. Turns out it was really important for people to actually see successful practice for them to engage in the training, as you can see at the top here. The other element is really a clash between roles. So this is partly people tended not to have much belief in the model. Partly for some people, it was because it seemed somewhat at odds with their job role, in the sense that if they were required to, for example, do a lot of risk assessment, do a lot of quite structured assessment, and had to information gather, the sort of solution-focused techniques didn't really seem very central to that, and so it was written off. The other factor is, as we mentioned before, we interviewed a lot of nurses, a lot of people that were very invested in medical model, which is often a highly expert model, and really it doesn't share a lot of the same ethos with the solution-focused approach traditionally. And I think that that kind of clash will put people at odds, make people discount solution-focused approaches as being useful. Yeah, so that was the other thing. The other positive thing that really helped people was if they felt a connection, if they felt an interest and motivation to be involved with solution-focused approaches. And as you can see, I'll flip back again because you can see there's an arrow that comes all the way from here, that if people had that, after training, they tended much more to proactively look for support to be able to extend and continue their practice. So that's there, but we'll move on to what happened during training.
So during training, if we kind of look at the bottom there, well, from what Ian said there around kind of there's a bit of a role clash, there's not a lot of kind of seeing successful implementation. What people kind of brought into the training then was having these kind of negative preconceptions. So basically that, oh, it's not going to work in this types of service, it's not really going to work with me because maybe I don't feel confident enough, or I don't see this working. That was kind of the negative preconception. And in order to kind of defeat that, like to counteract that negative preconception, it was very helpful for training to include very kind of realistic and a little bit flawed kind of, type of live demonstrations and role plays from the trainer themselves. So for example, they could have a role play where it wasn't perfect. There was a little bit of silence perhaps, or, there were times that they kind of were working towards the problem a little bit. So doing that in kind of like an imperfect way actually helps people feel more confident in the future to use solution-focused therapy. And it was also very helpful when it was relatable. So if it was kind of a medical setting, then actually saying you might only have 20 minutes or 10 minutes to actually use solution-focused principles. So you can use it in this particular way. So yeah, you can move on to the next one, Ian. So again, looking at the bottom, this is after the training. So looking at the bottom again, these early negative preconceptions, if they weren't dealt with in the training, they would lead to unrealistic expectations. So people would have then these expectations that, oh, okay, I'm supposed to use, in 20 minutes, I'm supposed to develop this whole goal list, or I'm supposed to identify all these strengths with the client, and it just wasn't feasible within that context. So they would have these kind of expectations that were obviously unrealistic. And what seemed to happen was that when they had those unrealistic expectations, they just thought that it didn't work. So rather than concluding that, okay, I need to do X, Y, Z to overcome this issue, they just thought solution-focused therapy is not going to work. And therefore they stopped using it. And it really, that kind of unrealistic expectation really interacted with lack of time and opportunity, as you can see on the kind of just above that, service pressures or problem-oriented clients. And what that meant was that, clients would go into, whether it's a medical environment or a different healthcare service, and they would be they themselves would be quite problem-oriented in their kind of way of thinking. And that would be quite difficult for someone who would be using solution-focused therapy from scratch. And so that would be a little bit of a barrier for them to use it then.
Yeah. Fortunately, there were quite a few things that supported and helped tackle a lot of these things. So one of them was actually what was really interesting to say. Well, we mentioned before that some people were set up properly from the pre-training point of having the interest peaked and having their and really developing a bit of motivation to learn about solution-focused work would proactively seek support. And it was really interesting that support networks, well, it sounds really obvious, but support networks were really important in maintaining practice. But what was interesting about this particularly was that that's usually considered to be, for example, follow-up ongoing supervision. But it wasn't the case necessarily that supervision was most important for these particular participants. For a lot of them, it was more about having a normalization of using solution-focused techniques in day-to-day practice, having peers and colleagues that were just trying it out and using it, not that we're necessarily experts, but just that it was the norm for people to do that. And it created this kind of solution-focused culture. And it was this culture that really kind of managed people's expectations, I think kept people going. So, I mean, Juul's example before of problem-oriented clients is a great one, because I think, those of us that have used the model for a while will know there is lots of ways around this, and around getting clients to think about what they might want and how, so how the model might really work with them. But without that kind of peer support and encouragement, that wouldn't happen. So I think it's really important that those things were there. Okay, so let's talk yeah, go on, Neil. Sorry.
Just going to mention very quickly, because Dwayne just had a really interesting question, that most of the barriers might be barriers to implementations might be systemic and systemic factors. And that's a really interesting point, because I think predominantly it definitely was. And actually it kind of shows, doesn't it, when the support network, which is the systemic element, is such a major facilitator, it really points towards a lot of these barriers indeed being systemic.
Yeah, Dwayne's stealing the thunder on our next bit, I think, because I think that's one of the things that came across. But it was, well, let's get into it, because I think it was really interesting in terms of what we found in terms of what you need to do systemically. But do you want to talk through the kind of highlights first, Juul?
I'll mention that first, actually. So what I guess one of the main findings was what obviously Dwayne is pointing towards, which is that actually solution-focused therapy in many ways could be seen more like a mindset, not just the specific techniques, etc., but more of a mindset. And so actually, when we found that there was that systemic facilitator, people could offer each other kind of like peer supervision. People would talk about solution-focused therapy in MDT, for instance, etc. Actually, the same impact that clinical supervision, one-to-one supervision would have, this provided. So it was a bit of a question of, okay, if we have that kind of systemic kind of facilitator there, how much do we need individual supervision? I'm sure that we do, but the question is how much. So that was an interesting finding. And the other finding as well, I'll kind of skip to the top, is around the change as a sacrifice. So we kind of looked into the theory of conservation of resources, which basically explains that any change at all costs. It's a bit of a cost to do that, because it costs familiarity. You might have to change the way you think. You might have to change your personality to some degree. You might have to change your professional approach. That costs. And so the way that a trainer should go in and kind of look at this is from that perspective of people come in here feeling like they've sacrificed. So it's almost like they need to be rewarded to some degree, because they are worried, or they might be a little bit kind of feeling like I need to prove to see it. And that's why it was so important to actually see evidence, because, it needs to be worth it types thing. So it needs to be,
I was just going to add to.
Yeah, go ahead.
I was just going to add to that, say, as solution-focused practitioners, I think we're very used to asking people about what their preferred future is. But I think when it comes to training, one of the issues is you can ask people where they want to get to, but then they won't know exactly how a solution-focused approach could be adapted or used in order to get there. So it's one of those situations where I think you need to sell it to people in terms of actually just showing them the way that it will get there, as well as what the outcome might be, which is kind of sometimes a little bit alien to us, I think, as solution-focused therapists.
Good point. Yeah. The last one I'll mention is just, we've talked about it throughout, but it really is to emphasize the importance of training as a journey. It's not just the training itself. What we found was that each stage seems to be just as important as the other. And actually, in fact, in order to kind of drive this implementation of solution-focused therapy, it needs to be that kind of preparation stage. It needs to be good training, and it needs to be maintenance factors as well.
Yeah, and I think that's the thing. I think there's a huge thing here about actually half of the training happens before the training. There's an awful lot of work that can be done in terms of, we'll talk about facilitating a culture here, which sounds like a massive thing. And, Dwayne's point about systemic change feels like it's a huge undertaking. But actually, a lot of this is just about pitching and getting people at all the relevant levels of an organization interested enough to have some value for this before you ever provide anything, almost to show people that there's some value added here. There's something that works, something that specifically will work in the context of the people that you're going to train. And if you get that to begin with, a lot of those factors then seem to permeate the training itself and what happens afterwards. So it doesn't have to be that you're revolutionizing a service so that it's only solution focused anymore. As long as, asking those those kind of questions is seen as normal and helpful at times, and having those conversations in MDT meetings is seen as okay and encouraged, that's the kind of context that really just makes it, that really encourages solution focused practice. And as we've mentioned a couple of times, I think the thing about having these demonstrations that are realistic, that are not perfect, but are relatable, are really, really fit with what somebody's doing and not just generic, is really important. But also that are fun and show, which is the third point here, that actually showing something working, showing people actually benefiting from the model, showing how it can be successful is really important. Okay. Quickly, I'm just going to mention some of the limitations on our research. So we're doing qualitative research. We're not suggesting that our 10 participants provide rules that is how all trainees operate when they're being trained in solution-focused techniques. What we were trying to do is provide a really rich, detailed understanding of some people's experience to give examples of how that might work and might be important in training. So it's highlighting things that then might be useful to include in training, that might be useful to consider, that might be worth looking at further, which you will talk about in a second. Of course, we had a self-selecting sample. We only interviewed people that were probably interested in the model because they agreed to be interviewed. We definitely didn't interview the people who refused to be trained because that didn't meet our criteria. So we missed out on a bunch of people when we were doing this. And the other thing is that, say, some of the training happened for people quite a long time ago, so they may not have remembered things well, they may not have remembered the training contact that well, and they may have had past experiences of psychological therapy which we didn't pick up on. So all of those things may kind of have meant that we had a certain kind of person talk to us about certain kinds of things. And finally, your research.
Yeah, I'll just finally mention then that kind of what was mentioned by Ian already. One of the things that would be very interesting is looking into, you know, how staff members who chose not to kind of attend a solution-focused therapy training program, why did they not choose to do that? Was that, maybe that could be confirming some of the things that we found, you know, was there that they didn't have that evidence already? Did they not believe in the model, you know? So actually looking at people who chose not to attend and actually having a bit of an interview with them would be really interesting too. Another thing that would be interesting is to compare the actual staff experiences with and without one-to-one supervision to answer that question of how much does one-to-one clinical supervision, which is quite costly in many ways in services, how much does that contribute versus kind of facilitating this culture? Because it's all about what costs the most in this point if we're trying to answer that question of developing the most effective training programs that maintain solution-focused therapy. The third one is just that one of the kind of main things that I felt throughout my interviews was that it was very emotive. You know, people were really connected with solution focused therapy, and they were so many of them were so encouraged to use them even before they've even seen solution focused therapy sometimes. So there was an interesting kind of value connection. So there's no research really that's really looked into why that is. And if we had a sense of that, maybe we can tap into it because it might be a valuable resource.
We should research conference attendees to find that out.
That would be the perfect participant group, wouldn't it? So, and then finally, just to confirm, I guess, the suggestions that we've made as part of this research, actually doing a bit of action research to almost assess and test whether these kind of suggested implementations would work or not.
Okay, right. We have almost no time. I realize we're on 31, but we are going to hang around a bit if people do want to hang on and ask any questions for 5 or 10 minutes before they go to the next workshop.